Hello friends, in this last video we will look into the remaining few slides, and the first one that I am going to take is TB lymph node. So this as per my opinion, in my opinion, this is a kind of very vast kind of a topic where you can get questions from the very basic immunopathogenesis of tuberculosis. And remember, first of all, the primary foci of tuberculosis is most commonly inside the lung, isn't it? And this TB lymph node, or you can say lymphadenitis, TB lymphadenitis is the most common extrapulmonary manifestation of tuberculosis. Most common extrapulmonary area where TB is involved is your lymph node, and this is called by the name of tuberculous lymphadenitis. There is an inflammation of the lymph node, so you call it by the name of lymphadenitis. TB lymphadenitis is the most common extrapulmonary manifestation of tuberculosis. Now, the moment we hear tuberculosis in pathology, what has to strike our mind is this particular term, that is granuloma, right? So the moment I hear the word granuloma, what comes to my mind is this is chronic inflammation, right? So granuloma is a morphological variant of chronic inflammation, or I can say granuloma is seen in chronic inflammation. And we have two types of granuloma, immune granuloma and a foreign body granuloma. Whenever a foreign body that cannot be engulfed on all of a sudden by a macrophages persisting inside the body, a granuloma will be formed with the foreign body at its center. That is called by the name of foreign body granuloma. Or we can have a granuloma like this, which is called by the name of immune granuloma. Yeah, immune system is involved, chronic inflammation is involved. There is no other foreign body over there, so you call it by the name of immune granuloma. So remember the two types of granuloma, immune and foreign body, right? So this is a kind of section from a low power view. You can say, yeah, low power in the sense that you cannot appreciate so much into it. Now this is a more magnified view of your granuloma. So this is a granuloma which you can very clearly make out over here, isn't it? This is a granuloma. Now this is again, I am just focusing on certain cells of the granuloma which are very important here, right? So let us actually first sketch out a granuloma, and then we will try to understand the very basic idea of granuloma from this particular picture. So as we know, granuloma is seen in chronic inflammation, so lymphocytes are involved. Chronic inflammation, the cells are lymphocytes, isn't it? So in the center, if it is a tuberculous granuloma, I will be having a necrosis here. And since this necrosis is cheese-like, I call it by the name of caseation necrosis. Caseation necrosis is a type of necrosis. We will have to discuss the types of necrosis also, because that is also a probable question. That is why I say that this is a very vast kind of an area, because you have more than one chapters which are involved in the pathogenesis of this TB lymphadenitis from your general pathology topics, and they can even ask a question on tuberculosis as well. So caseation necrosis is a type of necrosis where there is actually cheese-like appearance of the necrotic matter, and that is present at its center. Surrounding this, you will be having certain macrophages. So let's suppose that these are certain macrophages that I am making out here. Now these macrophages will undergo changes. What kind of changes does it undergo? They can fuse. And once they fuse, let me mark it with a different color here. When they fuse, they form these kind of, they fuse and they form these kind of very big cells which are called by the name of giant cells, right? If it is a tuberculosis granuloma, you get giant cells in which there is peripheralization of nuclei in this particular way. See, the nuclei are peripheral, and this is how the nuclei will occur, right? So this is how a normal giant cell appear in tuberculosis, right? So this is how the peripheralization of nuclei occurs, and there are very large number of nuclei can be seen over here. Now this kind of a peripheralization of nuclei will lead to the appearance which is typically called by the name of horseshoe appearance. Isn't it? It looks like a horseshoe, isn't it? This is how the whole thing is arranged on one part of the giant cell, and here it's almost there are no nuclei, so it looks like a horseshoe appearance, and these giant cells are called by the name of Langhans giant cells. Okay, so this is the very important classical name that you are supposed to remember here. Another important feature is that instead of fusing, these macrophages can undergo some modification and they can actually represent, or they look similar to a normal epithelial cell. So those are called by the name of epithelioid cells. So I can see epithelioid cells and the giant cells over here, isn't it? So I can't make so much of, I am not going into so much of depth of the features of epithelioid cells here. These are these are actually having the size which is similar to a normal macrophage, almost similar to a normal macrophage, but giant cells are very much big, very big, okay, compared to a normal macrophage. So just because of the fusion of many macrophages, that this kind of a giant cell is developing. So this is how the whole idea of a granuloma is there in tuberculosis, isn't it? So let us try to interpret the diagrams that are there here. So first of all, if I just tell you about this particular image over here, I can see that this is a typical picture of a giant cell, isn't it? So I can see these kind of peripheral nuclei, palisading of nuclei, peripheralization of nuclei can be seen. So this is a typical giant cell, and it is this place that the nuclei are present. I hope you can very clearly make out the nuclei which are present over there. So this is a very characteristic feature of your TB lymph node. Here I think this looks like a giant cell. I don't know if this is a caseation necrosis or a giant cell as such, but if I see this particular more zoomed in image, I can see this is a giant cell, and yeah, this is typically a giant cell. See how much big this is compared to a normal typical macrophage of somewhere over here, but this is a very big cell. It has a lot of nuclei which are arranged one after the other in the periphery, right? So this is called by the name of horseshoe appearance, and this cell you call it by the name of Langerhans giant cell. Okay, do not confuse it with the Langerhans cell. Langerhans cell is a macrophage of your skin, isn't it? And it is increased in Langerhans cell histiocytosis, but this is a typical appearance, and this is the granuloma that you are supposed to remember. So this is a granuloma, this is a granuloma. So this is how the whole granuloma looks like. This is a zoomed in image within a granuloma, right? So I hope you have understood the way we have to interpret a slide of tuberculosis lymph node. Let us talk about certain basic concepts in the topics of general pathology to understand this better. So this is a very probable kind of a question that does etiologies of granuloma. Let us talk about certain infections that can lead to the formation of granuloma. The first thing, how can we ever forget TB? How can we ever forget leprosy? Right? Then there is lymphogranuloma venereum. Right? You can have Q fever, cat scratch disease. Right? So these are certain bacterial infections. Let's talk about certain fungal infections also. Histoplasmosis, coccidioidomycosis. So these are certain examples of certain infections which can cause granuloma. Now, are there certain non-infectious causes also? Yes, there are. So let's talk about such causes here. Sarcoidosis, right? Tachysis arthritis, giant cell arthritis, right? You can have other conditions like Churg-Strauch syndrome, inflammatory bowel disease, Crohn's disease, right? You can have hypersensitivity pneumonitis. So these are certain causes of non-infectious granuloma, right? So in conditions like TB, syphilis, histoplasmosis, coccidioidomycosis, we will be seeing this caseous granuloma, but in leprosy and other conditions we may not see this kind of caseous necrosis at its center. So this is how we can differentiate a TB granuloma from a leprosy granuloma. So this caseous necrosis is a typical feature of TB granuloma. Now let us go into the basic features of necrosis. So I have written certain types of necrosis here. So first one is coagulative necrosis. What is the most common cause of cell injury? Hypoxia is the most common cause of cell injury. Whenever hypoxia occurs in all other organs except the brain, there will be coagulative necrosis, right? So this is the most common type of necrosis that you can think of. Now, liquefative necrosis is the type of necrosis which is happening in the brain whenever there is hypoxia in the brain. So this is seen in brain, right? Whenever there is cell injury in the brain, the type of necrosis is liquefative necrosis. So the tissue will become liquefied, isn't it? So that is colliquated necrosis, you can say that. But yeah, the tissues will become liquefied, the necrotic matter will become liquefied. This is also seen in infections. The most common type of necrosis seen in bacterial infection, fungal infections are liquefative necrosis. In TB, we will be seeing caseous necrosis. So, caseous necrosis, you can say it's almost a type of, coagulative plus liquefative necrosis. Some components of coagulative and liquefative necrosis will be there in caseous necrosis. And this is this kind of necrosis where you have cheese-like appearance of the necrotic debris, right? The necrotic matter will look cheese-like in the caseous necrosis. Fat necrosis is seen in those organs where there is high amount of fat, pancreas, breast tissue, these are certain examples of that. So, in pancreas, you can see that, okay, there is chronic pancreatitis, isn't it? In pancreatitis, what happens is this lipase enzyme of pancreas is activated. So, your triacylglycerol is broken to fatty acids by the lipase enzyme, which is activated now, and this fatty acid will combine with calcium to form soap. Calcium salt of fatty acid, isn't it? So that will lead to the formation of soap, and this reaction is called by the name of saponification. So saponification is a feature of fat necrosis. In fibrinoid necrosis, you will be having antigen antibody complexes depositing in the blood vessel. In the wall of blood vessels, you will be seeing this antigen antibody complexes depositing. So this can be seen in case of certain conditions like malignant hypertension. In malignant hypertension, you will be seeing this, right? And also we can talk about conditions like this Ascough nodules in rheumatic heart disease, Ascough nodules, which is also a type of fibrinoid necrosis in a way. Then you can talk about some other types also, which is the gangrenous necrosis, which is of two types, dry gangrene and wet gangrene. So I am just stopping this discussion of TB lymph node for now. So these are many other concepts which we have discussing from the topics of general pathology. So please make it a point to read these kind of topics, because these are highly probable, and this is a very basic features, very basic facts in the field of general pathology as well. So let's go to the next slide now, right? So now let's go into this topic now, that is granulation tissue. Right, so this is how we are now going to our next topic of general pathology again, a general pathology topic. So I don't know how far I can cover the topics in this particular small video. This is a very expansive topic so far as healing is concerned, isn't it? Wound healing is concerned. So yeah, some of those topics can be covered now. See, whenever a wound is healing, there is connective tissue deposition. So healing by connective tissue deposition itself is an expansive topic. So in healing by connective tissue deposition, you will be having angiogenesis first of all, right? Angiogenesis, right? And then after angiogenesis, you have the formation of granulation tissue, right? And in the granulation tissues, you have fibroblast. Now, whenever you have fibroblast, there is connective tissue deposition, and this connective tissue deposition leads to the formation of a scar, isn't it? So it leads to the formation of a scar. So granulation tissue, then there is a scar formation, and then there is remodeling of connective tissue. Right? That means what happens is that in scar it is collagen 3, and when it becomes remodeled, the strength of the scar should increase. So what happens is, while it is getting remodeled, this collagen 3 will become collagen 1. It is much more stronger than collagen 3. So it increases the strength of the scar. So this is the very basic function of remodeling. So angiogenesis is actually accomplished by VEGF, vascular endothelial growth factor, nitric oxide. Granulation tissue is thus produced here, isn't it? And scar formation, obviously it is with the help of your fibroblast, and yeah, we have this transforming growth factor beta, which is very important for the formation or laying down of collagen within the granulation tissue. So this leads to the formation of a scar. So collagen deposition is very much important within the granulation tissue so as to form a scar. And while it is getting remodeled, the enzyme here is matrix metalloprotease. So matrix metalloproteases are a type of enzyme which are actually functioning as the remodeling agents in the healing process, right? So this is the basic idea that you need to have so far as healing by connective tissue deposition is concerned. And now if you talk about this particular part specifically, this is the granulation tissue image that you can get in the exam, right? One look at it, I see these kind of blood vessels. So this is what is striking first of all. These are very important. Large number of blood vessels can be seen. See, angiogenesis is there, isn't it? So this leads to the formation of a lot of blood vessels. And let's just see here, lot of blood vessels can be seen over here. What else can you see here? I can see a lot of connective tissue deposition, lot of fibroblasts and connective tissue deposition. These wavy lines which you can see over here, isn't it? These are connective tissue deposition, which is represented by these kind of lines. So this is how you will be able to appreciate this in the diagram. Something else? Some bit of immune cells can be seen, lymphocytes can be seen in this kind of an image. So a collection of these things, blood vessel, proliferating young fibroblast and myofibroblast, and some amount of lymphocytic infiltration will be seen as in the granulation tissue. So remember, this is seen in wound healing. This is seen in wound healing, right? So the interesting feature is that as it heals, you will get reddish kind of a slough at the base of the ulcer, and this is called by the name of granulation tissue. Now you can have a big wound, so there will be large amount of granulation tissue, and you can have a small wound. So depending on the size of the wound, you will have corresponding amount of granulation tissue, and this granulation tissue itself is a sign of healing. Now once you have granulation tissue in an ulcer, you are understanding that this ulcer is healing. So this, yes, it's a good sign in a way. So let's actually talk about the features of the histopathology image like this. So proliferating young fibroblast and myofibroblast, right? I hope you are convinced with this. A lot of collagen tissue deposition is seen here, and that is because of fibroblast, and newly formed blood vessels are there. Perhaps this is the first important feature of wound healing, angiogenesis. Lot of blood vessels are produced with the activity of vascular endothelial growth factor, nitric oxide, etc., and also chronic inflammatory cells like lymphocytes and macrophages can be present. So a collection of all these things is what is meant by the term granulation tissue. I hope this is visible. I don't know if this is visible or not. I'm just writing the name here, right? So this is the basic idea of granulation tissue. Now let's just talk about certain factors that influence healing in an individual. Let's go for that now. So what I have done is that I have enlisted certain important factors which will influence the healing of wound in the human body, isn't it? So nutritional status is one of the most important point to remember. Here if you talk about a deficiency, like there is a vitamin C deficiency, if this is decreasing, then hydroxyproline, hydroxylysine cannot be produced, meaning collagen cannot be deposited. So collagen deposition is a very important feature of healing, and if that is not possible, then the healing itself is not possible. So yeah, nutritional status is very difficult. Now is very much important for the purpose of healing, isn't it? Metabolic, circulatory, if there is a block in the circulation towards that area where the wound is present, then that wound will have a difficulty in healing. Hormonal factors like glucocorticoids. Glucocorticoids are said to have this anti-inflammatory properties, and steroids have anti-inflammatory properties. So healing is further enhanced by those. Site, location, and type of injury is very important. There are certain parts of the body where actively regenerating cells are there. So in those kind of areas, if a wound is happening, then that wound will have more propensity towards healing, isn't it? And in certain other areas, like let's say that you have a myocardial infarction, those cells will have difficulty in regeneration. So that's the importance of site, location, and type of injury, isn't it? Now local forces, foreign body, let us suppose there is an excessive pull in the area where this particular injury is happening. Now do you think that wound will heal? No, because for a good amount of healing to occur, the edges should be opposing each other, isn't it? And that is not possible if there is high tension in the wound area. So yeah, and a foreign body in that particular area might hamper the healing. Infection is a very important thing that can actually hamper the healing. So there are many other topics in this particular section, so I'm not going into details of that, but I will recommend you to learn this. Primary and secondary intention in healing, isn't it? So those are very good topics to read. Extracellular matrix is a topic, component of extracellular matrix. So these are certain areas. The whole topic of wound healing itself is important when you talk about this kind of a granulation tissue, because you can get questions from all these kind of areas. So let's go to the next slide now. So perhaps one of the most easiest of all tumors to remember, to understand, to identify is renal cell carcinoma. So what you see here is the clear cell variant of renal cell carcinoma. You can see that the cell is containing virtually anything, isn't it? It is not containing anything. And the nuclei are pyknotic nuclei. Shrunken nuclei can be seen here, just like a dot. Just like a dot nuclei can be seen over here. It's just a shrunken nuclei which is seen over here. And these cells were containing glycogen and fat. And while the process of, making a slide was there, while it was being processed, the glycogen and other contents of the cell got washed away, leading to remaining this kind of an area, that is, clear cells with pyknotic nuclei. So these are the characteristic feature here, and you can have a delicate stroma which is separating the cells, which are actually separating the cell. A very thin stroma can be made out, between the cells. So this is how we actually identify the renal cell carcinoma. So there are clear cells which does not contain anything, and then it contained a lot of glycogen and fat, isn't it? And we have this pyknotic nuclei which is a characteristic feature, and we have this thin delicate stroma which are separating the cells. Let us go talk about some basic points about this. Now let us talk about the risk factors involved in the formation of the renal cell carcinoma. So the most important risk factor is tobacco, isn't it? So most important is tobacco, and many other things like obesity is a very important feature. Then you can have this estrogen, unopposed estrogen activity can lead to renal cell carcinoma. Hypertension, obesity is another risk factor, and heavy metal. Typically asbestos is associated with the development of renal cell carcinoma. So an occupational exposure of asbestos can have a long-term effect of formation of renal cell carcinoma, right? Let us talk about the subtypes here. Most common is clear cell variant, which we have seen now, isn't it? So you have a granular or flea cytoplasm, and you have a pyknotic nucleus separated by septum, isn't it? And then you can have papillary carcinoma, renal cell carcinoma, and here comes a very important feature. We have discussed this. This can have Samoma bodies. Dystrophic calcification, the calcium will be deposited in the concentric circle like arrangement. Chromophobe carcinoma is another type. XP11 translocation and collecting duct carcinoma, this is very rare. Collecting duct carcinoma is again very rare. Okay, so mutations, von Hippel-Lindau, very important to remember this. One of the most important gene is this one. So if you can remember this is well and good. And yes, clear cell variant can have von Hippel-Lindau defect, clear cell variant. Now papillary carcinoma normally shows this. So this is seen in papillary. MET gene mutation and TEF3 mutation will show this particular XP11 translocation. So this is XP11, isn't it? So in this particular subtype you will have TEF3 mutation. So these are certain features about RCC. Let us talk about few more points of RCC to complete this. Talk about the metastasis. So lung is the most common site. This is the most common site. Then you can have bone metastasis, liver, adrenal glands. Right, now as far as this bone mets is concerned, this is called by the name of pulsatile bone metastasis. So the pulsatile bone metastasis can be seen in two tumors. One is the tumor of thyroid. I think it is follicular thyroid carcinoma, and also in this renal cell carcinoma we can see pulsatile bony metastasis. This is very important. Paraneoplastic syndrome. Right, so the paraneoplastic syndromes are so many in number. Let us enlist them. First of all, ESR can be high. You can have anemia. We can also have polycythemia. This is paradoxical. So normally there is anemia, but in some patients paradoxically we can see polycythemia. You can have a leukemoid reaction. You can have amyloidosis. Right, you can have hypercalcemia. We can have Cushing's. Right. So yes, so these are the things which are involved here. You can have hepatic dysfunction. So these are certain paraneoplastic syndromes associated with renal cell carcinomas. Now let us talk about a very simple slide called by the name of cirrhosis liver. Right, identification is very easy. You have these kind of nodules which are surrounded by septae. Right, so these are your nodules, and whatever I am highlighting is the septae, that are separating the nodules here. Right, So first of all, understand the very basic feature in cirrhosis. You have a lobular architecture in the liver. We are aware of that. We have lobule, hepatic lobules were there. Now that becomes nodule. Right? This is the basic feature of cirrhosis. Now that is what is seen in this particular image. So lobular architecture to nodular architecture. Now it is nodule because it is cirrhosis. Fibrous septa surrounding the nodule. Yes, there is a fibrous septa which have marked in yellow highlighting, isn't it? The septa shows chronic inflammatory infiltrate. So what will you see here? Lymphocytal infiltration can be seen over there, and bile duct proliferation can also be seen over here. So there are many duct-like structures in this particular area, isn't it? So I think those are bile duct reactive proliferation. As a result of that, there is a secondary proliferation of bile duct due to the cirrhosis, due to the formation of nodular architecture. The bile duct will proliferate. Okay, so I hope now you will be in a position to understand that this is the slide of cirrhosis liver. First of all, this looks like a normal liver, but yes, it is nodular in nature, and there are tough septa, yes, isn't it, between the nodules over there, and you can see good inflammatory infiltrate over here. If I zoom in a bit, you will see blue dots over here. That means it is lymphocyte. And again, the last point was that there are a lot of reactive bile duct proliferation. Just look at this. There are many other vessel-like structures in this particular area, isn't it? So those are supposed to be the reactive bile duct proliferation. Now let us talk about the etiologies of cirrhosis liver. So you can talk about etiologies like alcoholic liver disease, right? Non-alcoholic fatty liver disease. This is an example. Now the third one can be viral hepatitis, hepatitis B and C. Remember, A and E are those kind of diseases which are acute, and these are chronic, right? Fourth one can be primary biliary cirrhosis, right? Fifth example can be metabolic hepatitis, like you can say hemochromatosis. Okay, alpha 1 antitrypsin deficiency. Right, now there are certain other causes also, like let's suppose this patient is having a right heart failure, and this eventually leads to the formation of cirrhosis. So this is called by the name of cardiac cirrhosis. Another one, idiopathic. What will you call this? You will call this as cryptogenic cirrhosis. Okay, so whatever be the etiology, this leads to a persistent infection, persistent damage to the hepatocytes. All these things causes persistent damage to the hepatocytes. So what happens is that this will stimulate the Kupffer cells. So the Kupffer cells will release platelet derived growth factors. Kupffer cells will release platelet derived growth factors and tumor necrosis factor. This will eventually stimulate the stellate cells. These stellate cells will secrete the which one? Transforming growth factor beta. Whenever this is there in pathology, we understand that there is excessive amount of connective tissue deposition. Right? The moment we see transforming growth factor beta, we understand that there is fibrosis in that particular area. So that is why the classical feature of cirrhosis is bridging fibrous tract from the portal triad to the central vein. So we know that it is hexagonal in structure. The lobules are hexagonal in structure, isn't it? So here somewhere comes the portal triad, and here somewhere comes the central vein. And between these two things, there is bridging fibrous. To bridge it, there are fibrous structures which are connecting, fibrous septae formation between the portal triad and the central vein. And then the lobular architecture becomes nodular. So these are the very basic features of your liver cirrhosis. Let us now go to the next slide. Now this is a salivary gland tumor which is benign, right? This is a benign salivary gland tumor, most common salivary gland tumor, and 60% occurs in parotid gland. 60% of parotid gland tumor is obviously pleomorphic adenoma, right? So it is so much common so far as salivary gland tumors are concerned. Now the point is that the first word itself says it is pleomorphic. The morphology is variable. Heterogeneity in the morphology is what is the characteristic feature of pleomorphic adenoma. So you can see that there are epithelial component and mesenchymal component. So epithelial component can be in the form of acinus, gland, duct, whatever. and mesenchymal will be in the form of cartilage or bone, isn't it? So that is how you can see all these things. It's just like a teratoma. It reminds me of a teratoma, but yeah, not that kind of a tumor, but this is a different kind. But remember, epithelial and stromal components are present. Epithelial and mesenchymal components are also present. So epithelial components can be ductal or myoepithelial cells, right? Acinus, glands, everything can be there. And stromal component is loose myxoid tissue containing islands of chondroid and rarely foci of bones can be seen. So a very variable kind of a image is seen over here. So this is a kind of tissue. Now this is some other kind of tissue. This is how the heterogeneity has been given in this particular image. So that is how we actually identify image of pleomorphic adenoma, and if there is a history, then it's much more easier to find it out. Right, now let us talk about certain benign tumors and certain malignant tumors affecting the salivary glands. You are supposed to remember the names of these. Pleomorphic adenoma, Warthin tumor, oncocytoma. These are examples of benign tumors. Malignant include mucoepidermoid carcinoma, adenocarcinoma, acinic cell carcinoma, right? So these are certain examples of malignant. So there are more examples for that, but let's at least remember 3 examples in each of them. 3 or 4 can be learned at this level, right? So let's go to the next slide now. So carcinoma breast is a very expansive topic, but the slide that they are keeping is ductal carcinoma. So it is, the new name for this is no special type, isn't it? NST is the new name for ductal carcinoma. Now the point is that we are supposed to first of all understand the types of carcinoma. Here we have a molecular classification, and we do have another classification called by the name of histology classification. So molecular classification is something else, but histology classification is based on whatever we are seeing by the process of biopsy. So what happens is here is that you have a NST and we have a special subtypes, and there are many other types. This can be lobular carcinoma. In lobular carcinoma, what is the feature here? Here you have decreased E-cadherin expression. E-cadherin expression is low. So you have this Indian file-like pattern, which is very typically seen in lobular carcinoma. You can have mucinous, you can have medullary, you can have tubular, you can have inflammatory, you can have papillary carcinoma. So these are certain subtypes and special subtypes. And the other one is NST, no special type. Right, so yes, these are certain features which are seen over here. You can remember this. Malignant cells can be seen in sheaths, nest and tubules, and if I talk about this individual malignant cell, it has eosinophilic cytoplasm and pleomorphic arrangement. Hyperchromatic nuclei, pleomorphic hyperchromatic nuclei with prominent nucleoli, lot of numerous mitotic figures can be seen. So all these are suggestive of malignancy, isn't it? Areas of necrosis and desmoplastic stroma. So that means there is high connective tissue deposition here, isn't it? That is why we call it by the name of desmoplastic stroma. You can see very clearly how desmoplastic it is. A lot of connective tissue deposition is there in the stroma. So that's the basic feature. Now, if I start discussing about the features of carcinoma breast, then the length of this video will go so much high. So we'll just tell you what are the important points here. You need to talk about the risk factors. We are supposed to remember the prognostic factors, right? These will get it as a sub questions here. Then we need to know about the subtypes here. Now there is a molecular subtype also, isn't it? You can have this one, luminal A, luminal B. That means ERPR positive, HER2 negative. Both of them, they are luminal A and B. In B, Ki67 is high. That means the proliferation of the cells are much more in luminal B. Then you have a triple negative, which is also called by the name of basal-like, and HER2 enriched. That means only HER2 new is positive. So based on the expression of these receptors, we are classifying the carcinoma breast into these kind of subtypes. So those are also a very important question, isn't it? And these are the types of questions that you can expect for the as sub questions whenever a question of carcinoma breast is given in the exam. So I would recommend you to go through this topic and learn all the important points because they can be asked as sub questions. So far as this slide is concerned, you can remember these kind of points. And yes, that's all with carcinoma breast. It's a very expansive topic. Now let's go to the last one. Now let us go to the topic of adenocarcinoma colon. First of all, whenever we hear the word adenocarcinoma, right, it simply means that it is a carcinoma of gland. Okay, so what do you mean by glands here? A gland will be in the form of acini in the histopathology image. So you have columnar epithelial cells which are lining over here, isn't it? Now these columnar cells will become malignant. So you will get a picture somewhat like this. This one. So you can see a lot of acini kind of structures in this particular image. And these acini are having malignant glands. So, hyperchromaticity can be seen, NC ratio is deranged, and all the other features of malignancy can be seen in the cells which are lining the glands over here. So, these are your glands which are malignant here, and that is how we actually find out whether a carcinoma is an adenocarcinoma or something else. So, adenocarcinoma simply means it is a carcinoma of glands over here, and you will see atypical glands or malignant glands in this particular image, right? So if I just start talking about this, nothing else is there in this particular description other than saying that okay, this is actually a carcinoma of glands. Cells are arranged in glandular pattern, we are aware of that, and then there is some basic idea about this particular cells. Cells have moderate cytoplasm, pleomorphic, hyperchromatic to vesicular nuclei with prominent nucleoli. So these can be appreciated in this particular image. You can see a hyperchromatic nuclei in this, and with even nucleoli can be seen over there. So this is a high power image, you can say, of the gland. So this is a big gland that you can actually understand from this particular focus. Now back to back arrangement of glands can be seen. So one gland, another gland behind this. So that is how it is arranged. So a lot of glands can be seen. These are malignant glands. So they have all the properties of malignancy. That is why this kind of a sentence has been written over there. Back to back arrangement. One gland over the other. Stroma desmoplastic, connective tissue deposition is there, the stroma, excessive stroma is there with dense inflammatory infiltrate. I hope this is visible in this particular image. You could see that there is a dense inflammatory infiltrate. Everything is looking blue in this particular image. A lot of inflammatory infiltrate is seen over here, isn't it? So that is how the whole thing is given in the topic of Adenocarcinoma colon. So if you talk about the risk factors include dietary fibers. You might know what is meant by this very basic term of dietary fibers. You might have heard that even in Indians, this adenocarcinoma colon is having a lesser amount of predilection because fibers are very much high in the diet followed by Indians. It's a sentence that is there in all textbooks, isn't it? Although we don't know the latest edition of everything, but yes, dietary fibers are supposed to be protective in nature. Antioxidants, let's suppose you have vitamin A, vitamin C, these are supposed to be protective. Vitamin E is also protective. NSAIDs have a protective effect because it prevents proliferation kind of a thing, isn't it? Yeah, I mean excessive cell growth can be prevented, and yes, a carcinoma, there is some sort of a protection that is also shown by NSAIDs. Now if I talk about certain mutations over here, you must be knowing that APC beta catenin pathway is the first type of mutation that is possible over here. Other than that, you can have DNA mismatch repair defect. So you can have a problem in the microsatellite pathway, isn't it? And you can have mutations in the CPG island also. These are certain genes here. And on top of that, you can have our favorite things like RAS gene, P53 gene, right? So these are, now what type of RAS here? K. Now I remember it as colon. So yes, K RAS is associated with colonic malignancy. So yes, these are certain features so far as the adenocarcinoma is concerned. So with that, we come to the end of all discussions of the slides that are possibly kept in the examination. Thank you.